بس اقدمك بس اقدمك بسم الله الرحمن الرحيم. اهلا وسهلا مره ثانيه في السيشن الثالث ليومنا العلمي. واحنا صحيح البرنامج كنا عاملينه من فتره طويله قبل ما تصير التعليمات الاخيره بالتقليل على ساعات التجول. كان البرنامج للساعه 8 لكن بما انه صار في تعديل مش رح نضل الساعه 8 حتى الناس ممكن تروح. وامبارح كان حجر كمان ما بدناش يعني نضغطوا زياده عن اللزوم. فمضطرين نعمل هذا السيشن الرابع نأجله الى لقاء اخر ان شاء الله. فبنبدا السيشن الاخير مع الدكتور اشرف اجبارات and he will talk about management of mild to moderate bone defects in acetabular revisions. تفضل دكتور اشرف.
شكرا دكتور ايمن. السلام عليكم. Good evening everyone. I'll try to be quick. My talk is going to be about the management of mild to moderate bone defects in acetabular revisions, which is My talk is going to be about the management of mild to moderate bone defects in acetabular revisions, which is a quite crucial subject for the revision surgeon to consider because eventually it will determine the failure or the success of a given revision surgery. Just a quick review of one of the most commonly utilized classification system of acetabular defects in revision surgery in hip, the Paprosky classification, developed by Professor Wayne Paprosky, which is a detailed descriptive system based on the absence or presence of 4 key pelvic supporting structures. Those structures are the superior migration of the acetabular cup away from the superior tracheal line, represented in this photo by the line B. Next is the position or the location of the acetabular cup in relation to collar line. Third and fourth include the absence or presence of ischial or teardrop osteolysis. So, according to Paprosky classification, there's type 1, which includes the presence of small capillary defects with intact acetabular rim and intact forepelvic supporting structures. In type 2, there will be a superior migration of the acetabular cup away from the superior tracheal line by less than 30 millimeters. And this migration can be either in the anterior medial direction in type 2A or in the anterior lateral direction in type 2B or a pure medial migration in type 2C. And in all subtypes of type 2 defects, there will be minimal ischial and teardrop osteolysis. Type 3 involves the presence of more than 30 millimeter migration, superior migration of the acetabular cup, which can be either the up and out defect in type 3A or the type 3B or the so-called up and in defect, which can be associated with pelvic discontinuity. So my focus will be included in the mild to moderate bone loss, excluding the more severe forms of acetabular bone loss or the pelvic discontinuity. And this is the simplest way to categorize the defects. It's a lot easier than to be before because we have gotten better in treating them. So the mild to moderate bone loss, Paprosky 1, 2, and some milder forms of the type 3 defects. I think it's fair to say that for the great majority of this type of defects, the mild to moderate defects, your implant of choice would be a cementless hemispherical acetabular socket fixed with screws. And hopefully it will be the last surgery that the patient needs, thereby stopping the cycle of revision surgery that is so damaging to the bone. And again, the hemispherical sockets are really available in whatever setup that you have in your OR. Why we got this technique? We got it because it's the simplest technique and it also has the best results. Sometimes those two go hand in hand. And of course, it has a number of theoretical and practical advantages First, you get biologic fixation. You get your cup against a host bone, healthy host bone. It's versatile. You can apply them to many types of defects, and it's also technically straightforward. And it does allow you the placement of particulate bone graft medial to the cup. It's also worthwhile pointing out that as the large cementless cup became available, they have extended the range or the spectrum of bone deficiencies that can be easily managed with the hemispherical cementless cup. Why does this method work? Well, it works because it allows you to get your cup against a healthy host bone and fix the cup with multiple screws. And once you get this cup against a healthy host bone, hopefully you will wait for the osseointegration to happen. I would like to point out and emphasize that the point is not to try to use a large cup rather than using whatever cup size is suitable or suitable for your bone defect, because in most of these defects there will be a sizable defect, and the easiest way to fill this defect is with a hemisphere. I'll show you an example what I mean. If you can look at the left side of the X-ray, you can see this, of course, loose acetabular cup. And when the revision surgery did this surgery, he used a modest diameter cup. It's larger than the usual cup, but still it's not that large. He managed to put the cup against the healthy host bone, aligned mainly on the acetabular rim grip, and he fixed the cup with multiple screws. And again, medial to the cup, he used particular bone graft, and you can see after 10 years of the index revision surgery how bone reconstitution is beautiful. Again, the same situation. The large cup was used in this situation. The old cup was removed, and the larger one was used against the healthy bed of acetabular bone, and the medial defect was grafted. Now we come to the jumbo cups. Jumbo cups, or a jumbo cup is defined as a cup that's at least 10 millimeters in diameter larger than the cup used in the primary setting for the same patient. المريض كان بالبرايمري usually بالبرايمري total hip إذا استخدمت socket size 50 millimeter, his jumbo cup for the same patient would be 60 millimeters at least. The results of the jumbo cups are pretty clear. A number of study groups have been published. This one is from my clinic, Rochester, and they have concluded 88% of survivorship free of aseptic loosening 20 years after follow-up. A pretty good result, even with the use of the standard uncemented cups that were available in the old days. Nowadays, with the highly porous cups that have the enhanced fixation surfaces, the trabecular metal or the porous metal, we do even better. I would like to talk about a few technical points related to the use of jumbo cups in the setting of revision total hip. The first point and the most important point is the key point about the start of the surgery, of course, after gaining adequate acetabular exposure, is to center your remar. So how you handle the remar really matters, and how you center your remar really matters. And your goal should be to center the remar, so you would create or produce a hemisphere of supportive bones that you can put your cup in. Also be cautious, as the remar tends to bounce around in revision surgeries. So handle it with an element of confidence and with an element of gentleness, so it doesn't catch big pieces of bone and take them away and damage the remaining bone stock. Next is to create a chamfered hemisphere of supportive bone. If you look at the X-ray, the left one, you can see this is a small piece of bone should be taken away, so you can create a horizontal chamfer laterally, and this piece inferior should be also removed to create a vertical chamfer that you can pinch your cup against and get the grip that you need by the acetabular rim over the cup. So to get a solid cup fixation, we typically like to do a press fit technique, which is the friction fit of the cup against the supportive bone, and you do that by under-reaming. And for most cup designs and sizes, the 2mm under-reaming is quite right. So you can wedge your cup into the pelvis and use the grip of the acetabular rim to stabilize your cup. Of course, if you can manage to get some dome support, it would be okay and good, but eventually the acetabular rim grip will determine the risk of cup migration. As you can see, and this arrow represents the lateral chamfer that we talked about, and this one represents the vertical chamfer or the inferior chamfer, and this arrow represents the dome support that you might need to graft. Again, if you want to get the solid cup fixation, you need to fix your cup with multiple screws, and of course, most of the cups should go through the ilium, but sometimes you need to put screws inferior to the equator of the cup and into the ischium. With the cementless sockets comes the question of how much fixation is enough and how much bone contact is enough. Of course, we would like the bone contact area or bone contact surface to be maximized, but this is not always 100% possible. Sometimes in revision settings, you end up having only 50% contact between the cup and the acetabular bone. But with the high friction biologically active surfaces, now we can do as low as 40% of bone contact with the cup to get a good osseointegration. This photo represents the new trabecular metal cups that you can place extra screws through it. You can drill your screws in any direction that you feel will be more stable for the cup, and you'll be able to use this cup as a porous hemispherical cage. Now, some of the most commonly happened technical errors during revision surgery. First thing is failure to use a large enough cup. As you can see in the left X-ray, the primary surgeon failed to get enough large cup. So 3 weeks after, not surprisingly, the cup migrated medially and failed. So it's important to get the size of the cup right. Next, you should be careful not to take away the posterior wall, especially if you're dealing with a jumbo cup. When you're planning to place a jumbo cup, you have the tendency to use a larger reamers. The larger reamers tend to take more from the posterior, especially in the revision settings. The anterior wall mostly would be gone. So if you take out the posterior wall during your revision, you might end up with cup instability, and in this case, the revision surgeon has to place a large structural graft on the posterior wall and fix it with a plate so he can get his socket stable. Again, an example of using a jumbo cup in large defects and grafting the medial defective particulate bone graft. This X-ray is like 4, 5, or 6 years after surgery. Another situation of a failed cup migrated medially, it was taken out, a larger cup or a jumbo cup was used and fixed with screws. The medial defect was grafted, and now it's reconstituted. Another example, the same situation. The jumbo cup was fixed with screws, and it looks stable. One last example of a massive defect that was treated with a jumbo cup, and this fixed with screws. Again, the medial defect was grafted, and you can see the remodeling immediately. Thank you. That's all.
السلام عليكم جميعا. Okay, my talk is going to be about patient satisfaction after total replacement. This subject is actually underestimated from the point of view of many surgeons. So I'd like to raise the flag here. Let's start with the learning outcomes. We're going to raise the issue of knee satisfaction after primary total knee arthroplasty. We'd like to identify the probable risk factors for knee satisfaction. Identify كيف نرجع مرة سريع page up. And I will end the talk with kind of new knee system design that's getting trending all over the world. Dissatisfaction means that the patient will be happy. In our own language, it means like the patient ممكن يحكي مش مبسوط مثلا او ندم اللي عمل العمليه. خلينا نحكي هاي المصطلحات الاقرب جزء بلغتنا. Total knee replacement, generally speaking, is a very successful surgery. Unfortunately, 1 out of 5 of those patients get dissatisfied after surgeries. So this is actually a big percentage of patients. We still talk about a relatively vague field here because the research is not quite enough talking about this subject, and this subject is actually vague to measure and very difficult to assess and differ from patient to patient because it's the patient's feeling. It's like a subject issue, not like an objective thing we can measure using functional scores or whatever we use usually. This is our study. We talked about 3 factors. Studied the psychological status, implant type, and BMI in patients undergoing total knee replacement. This is a quote used by many arthroplasty surgeons. The hip is like a mother, and the knee is like a wife. So it's not the usually hip patients are more satisfied than knee patients. This is approved in the literature as well. We use the Likert scale, which is a very common, simple one. The patient is either very satisfied, or neutral, dissatisfied, very dissatisfied. We count satisfied patients and very satisfied patients as happy patients with their surgeries. The problem, as I said, is that satisfaction is usually something you cannot measure, such as the case in many functional and pain scoring systems. So it depends on the patient himself or herself. This nice study talking about PROMs and knee replacement, it came from the HSS. I wanted to start with it. We studied the implant type and found it doesn't really matter. This study actually came to the same conclusion. Implant type doesn't lead to different outcome in most of the patients. I'm talking about the PS knees and the CR knees. We're going to talk about the third system later on and discuss maybe this is going to be the future. This study came from Indiana. They are talking about a new concept, trying to measure the satisfaction, which is, as we said, very hard to measure. They used the artificial intelligence. Dr. دكتور مالك امبارح حط شغله حلوه وذكر انه artificial intelligence is the future. Machine learning is very rarely used in orthopedics, unfortunately. This article is one of the first to use machine learning in orthopedics. It's used and it's there since maybe 40 years, but for a reason or another, it's late in orthopedics. Some of the risk factors, what really matters in satisfaction is to look for those pre-op or modifiable risk factors, because those what we can change. There are many risk factors, as you see, starting by demographics. Females usually are more dissatisfied. Concerning the age, the elderly are more satisfied. The younger usually are more dissatisfied. Obese patients with a BMI more than 40 usually are more dissatisfied. Patient's expectation is a very important factor, because if the patient thinks he's going to get rid of the pain 100%, he's going to be in trouble. So this is an important point. Psychological status with psychological diseases also is another important factor. Diagnosis, inflammatory are usually worse. Severity, the severe, the bad knee is usually not necessarily going to get the most benefit as many of us think. The extremes are really bad. The most severe types of knee arthritis and the mild early arthritis are usually unhappy patients and usually don't get the satisfaction we look for. Technical issues such as size, for example. This is not a true knee problem like infection or instability or stiffness. This is like a simple technical issue that would lead to a dissatisfied patient. This is the patient, like this thing the surgeon should look for and be aware for those fine details. Deferred pain is a very important one. It's either the back or even the hip in many patients. Muscle weakness, of course, is another factor. So we should differentiate between dissatisfaction and a true knee problem that might need a revision, a full revision. Usually, knee revisions are full revisions, most of the knee revisions. The best results are to do the femur and the tibia. And if the patella is there, you can leave it. But usually, knee revisions should be a full revision. So it's a big surgery, sometimes for an unnoticed or undiagnosed thing. So we should keep a big eye on those problems. Those problems such as infection, for example, instability, aseptic loosening, stiffness, fractures, patellar maltracking, malrotation, malalignment, these things should be kept in mind first and ruled out in any dissatisfied patient. Because those are correctable things we can control and can change the patient's situation. You mentioned that. Okay, this study came. This study is talking about the medial pivot system that I'd like to briefly talk about. It's a big subject. I will briefly introduce it here. The idea of medial pivot system, we have the CR system, which has surgeons who prefer it. We have the PS systems. The third thing is the medial pivot system. This is the third knee system worldwide. It's not a new thing. It's there since the 90s, and it's getting more and more common now. It's started to be, let me say common, not very common, but it is common now in North America, some parts of Europe. So medial pivot knees are different from the classical PS knees by not having the post and cam mechanism, so there will be less bone loss. And they differ from the CR knees, like they are ACL, PCL deficient, or like sacrificing kind of systems. So this system depends on getting the most, let me say, the closest way to look like a native knee. A native knee usually have a ball and socket on the medial aspect, which is usually less mobile than the lateral aspect. Lateral aspect have some AP translation that's not usually or cannot be initiated or found in PS or CR knees. So this system depends on a ball and socket on the medial aspect, on the medial side, and a AP translation motion. We'll talk about it more thoroughly soon on the lateral aspect. There is 10-15 degrees of AP translation. This makes femoral rollback more efficient and gives you more range of motion, and at the same time preserves or keeps your knee stable after surgery. As you see, this is the lateral range of motion. It's like 10-15 degrees, which is good, or enough, I mean, and very similar to the native knee. This is a femoral rollback. We usually aim to get, generally speaking, as we said, those are the knee systems. Mobile bearing is no different than any other knee system. Some surgeons don't find it the best thing to usually use. PS knees, as we said, have this post and cam mechanism. So the post and cam aim is to prevent tibial subluxation, right? So in the medial pivot system, we don't have this post and cam, but we have a raised lip, different polyethylene than the regular one. They have raised lip on the anterior side, substituting the ACL, and they have a raised edge on the posterior aspect as well, which represents or substitutes the PCL. So the knee is more stable with the medial pivot joint with more range of motion, as we mentioned. Take home messages. As we said, knee satisfaction is a very important issue for any orthopedic surgeon. It's 1 in 5 patients worldwide, a dissatisfied patient after primary total knee arthroplasty. We should keep an eye on the real knee problems, identify them, treat them if necessary, and differentiate them from the dissatisfied patients. And I'd like I hope I delivered the message of the medial pivot knee systems versus the traditional PS and CRA systems. Thank you very much.
Bismillah ar-Rahman ar-Rahim. Hello everybody, today we'll talk about osteolysis and total hip replacement. In general, the total hip arthroplasty is one of the most successful procedure. It's reached up to 97%. So increasing with the demand of the total hip arthroplasty, that rising with the increase of the complication of the total hip. Why osteolysis? Because the osteolysis is one of the most common complication post total hip arthroplasty at the long term, up to 20 to 40%. So the definition, what's the osteolysis? The osteolysis is a progressive condition where the bone tissue is destroyed. In this process, bone loss mineral, mostly calcium, soften and degenerate and become weaker. It's the osteolysis is time dependent. It's inflammatory process reaction to the wear particulate. We will start by evidence to show how it's a common complication post total hip. We collected 17 patients underwent revision for their primary total hip in the period between September 2019 to the September 2020. we found 11 of 17 patients with osteolysis, the cause of the revision of the total hip. So it's common. It's about 65% of the causes. 2% with infection, 2 patients with dislocation, 2 patients due to periprosthetic fracture, and 1 patient for impingement. So it's common complication that may lead to revision of the total hip. The step in the process, it's include 4 steps. It's started, then become viscous closed cycle, increasing and progressive with the time. Started with particulate debris formation, macrophage activated osteolysis, prosthesis micromotion, particulate debris cementation. From where the particulate debris come, there's 2 sources. The most common is the wearing, which leads to particulate debris formation, corrosive, which is the electrochemical reaction to the metal. The wear is 4 types. Adhesive type, which happens between articular surface of the component. Abrasive type, which happen at side shearing force. Third body wear happen due to foreign body or material in the joint space. Will linear describe the wear, how vertical distance wearing in the material. So many material involved in the total hip, different by wearing rate, like polyethylene, which is the most rate. It's up 0.1 to 0.2 millimeter per year. Ceramic, the best resistant material to the wearing. It's about 0.5 to 2.5 micro per component per year. The metal, it's between the polyethylene and ceramic, ranging from the 2.5 to 5 micro per year. So the wearing rate, it's different according to the material we use. This is the metal with polyethylene. Cross-link is less rate than uncrossed. Ceramic is the best. So how it happens? It's debris formation start, then macrophage will eat in this debris, releasing cytokines like interleukin 1, interleukin 6, tumor necrosis factor A, that lead all of these that lead to the activate the osteoclast. Osteoclast will express the rankle. Rankle will bind to the receptors on the osteoblast, on the osteoclast, and activate the osteoclast and degenerate the bone by resorption. In general, in the loosening in the total hip, according to the cemented or cemented-less, cemented total hip arthroplasty, a stable component often starts to fail. In the cemented list, the femoral component often to fail. In general, in the cemented total hip, it's the loosening or osteolysis occur in the implant cement interface in the femoral component and the bone cement interface in the acetabular component. There's a zone for the loosening. Describe the extension of the loosening. This zone help us in the grading and staging, and know the extension and the progression of the loosening, which help us in the treatment later on. In general femoral component, there's a groin zone system, a acetabular component, Dili and Charlie zones. We will describe. In the femoral zone, 2 X-ray for the hip, AP and the lateral. In the AP, there's 7 zones started from the greater trunk up to the 4 zone in the tip of the prosthesis, then 6, 5, 6, 7, and the 7 in the lesser trunk. In the lateral X-ray, we saw the zones started from the 8th zone, present in the anterior aspect, and end in the 14th zone on the posterior aspect. The most important zone is in the AP, the 4 zone, and on the lateral is 11 zone because it's started of migration. This is the zone of the acetabulum. It's 3 zones: superior lateral and middle and inferior medial zone. 1, 2, 3. All of these zones later on will help us in the know the progression and the grading of the osteolysis. In general, in the cemented, we'll start with by femoral component osteolysis. Cemented. There's 2 systems. One of the system is Barak grading, A, B, C. The A, it's the medulla canal without radiolucent line, white out. Then type B or grade B, the radiolucent line less than 50% of the cement bone interface. C, it's about 50 to 99% of the cement bone interface. D, it's complete radiolucent line. It's about 100%, and absent maybe of the cement distally at the end of the stem. This is X-ray for all of the zones, or grade A, B, C, D. There's another grading system for femoral loosening. It's Harris grading. It's 3 types: possible, probable, and definitive. In the possible, the bone cement lucency less than 50%, mainly due to poor cement technique. Probable, continual line more than 2 millimeters with local cavitation. 3, it's started in the zone 4 on the tip of the prosthesis, and after that, stem migration going in the varus and pistering effect. Radiolucency is more than 2 millimeters in other zones. There's a classification for this classification for cemented less femoral component. It's 3 types. 1 and 2, it's stable. Type 3 is unstable, start to migrate. But the difference between type 1 and type 2, it's the first one is bony ingrowth, stable by bony ingrowth. Type 2 by fibrous ingrowth. So stable, type 1 stable bony ingrowth. There's a spot, a wheal at the end of the porous coating, absence of radiolucent line, carcal atrophy due to stress shielding. This is a spot wheal in the tip, on the tip of the prosthesis. The type 2, it's stable, but stable by fibrous ingrowth. There's no spot wheal, and there's, as we see in the X-ray, there's a parallel sclerotic line, radiolucent line. It's around about porous coating, but still stable. There's no migration. Type 3, it's unstable, started to be migrated, component migration, progressive, increasing in the radiolucent line. There's distal formation, bony hypertrophy at the tip. Now, how the failure how the mechanism of the failure of the femoral component, they described by 4 types. The type 1 starts with subsidence or migration, upward or downward. Type A, like as we see in the picture. Type A with the bone cement. Type B with the bone with cementless. Then 1 minute. Okay. This is subsidence. This is the mechanism of the stem failure. Our oral site is loosening non-cancellous bone, normal aging process. Technical error, many technical errors like cancellous bone, medially inadequate quantity of cement, present of cement void. cemented acetabular loosening, its bone cement أكثر من 2 mm or progressive, migration and protrusion of the cement, change in inclination more than 5 degrees, eccentric polyethylene. Uncemented cup loosening, their sign, radiolucent line appear after 2 years because it's normal in 1 year. Progression of the radiolucent line involved in three zones or more than 2 mm. This is in conclusion, a classification for cementless acetabular cup, stable bony ingrowth, type 2 stable fibrous ingrowth like femoral, the type 3 unstable fibrous ingrowth. Technical problem, same the femoral, inadequate support of the cup, failure to remove the cancellous bone and cartilage. Diagnosis in general by history, pain, started at the start-up pain, physical examination, antalgic gait, limb length discrepancy. Investigation, we concentrate to rule out infection. Imaging, X-ray to show the progressive fraudulency and migration of the implant. Take-home message, good procedures in general, it's important. It must be stable, pain-free, functional, and valid as we can. Thank you.
Assalamu alaikum wa rahmatullah. My talk today will be Patellar and total knee to resurface or to not. Actually, this is still controversial worldwide, controversial topics. International perspective, currently 3 surgical approach to the patella worldwide. There is surgeon who always resurface, surgeon who never resurface, and other surgeon who selectively resurface. In general, North American surgeons tend to always resurface the patella. Unlikely surgeons like us in Asian country tend to be selectively resurface or never resurface the patella. It may be due to short stature and thin patellar bone. Multiple biomechanical studies of the patellofemoral joint in total knee have focused on the kinematic and contact stress. As we know, the most common complication after total knee replacement is anterior knee pain due to patellofemoral maltracking. But more anatomic trochlear design in the total knee prosthesis can reduce actually the patellofemoral complication. Trochlear design, we mean lateral orientation of the trochlear group, prolonged and deepen intercondylar notch and high lateral flank. Indication, absolute indication for patellar resurfacing is inflammatory arthritis, severe osteoarthritis of the patella for any other cause, idiopathic traumatics where there is severe cartilage damage, non-anatomic trochlear group or femoral component. Actually, patellar resurfacing based on patellar bone stock, the decision based on patellar bone stock, patellar shape, articular cartilage, characteristic, and host factors. We will talk briefly about technique in patellar resurfacing. First of all synovial tissue removed up from the quadriceps tendon down to the patellar tendon. The top of the patella is cut with bone saw, either freehand or using special guides. Thickness of the patella measured with a caliper to measure 4 quadrants of the patella. Uncovered bone of the lateral facet resected to decompress the lateral gutter. Appropriate size trail of the plastic patella applied. And the most important step is to assessment the patellar tracking. Patellar components should be centralized or medialized, never lateralized, because lateralization will increase the Q angle and cause patellar maltracking and lead to more anterior knee pain. Actually, when we are patellar resurfacing versus non-patellar resurfacing complication including patellar instability and dislocation, aseptic occlusion, polyethylene wear, patellar clunk syndrome, and patellar fracture and patellar AVN. Non-resurfacing complication is usually with facet, anterior knee pain, and may requiring of a second resurfacing. These studies are comparing between patellar resurfacing versus non-resurfacing. Actually, there is no difference. Most of all studies about pain, patellar replacement doesn't guarantee painless patellofemoral joint, and metal-backed patella and patellar component has higher complication, no significant benefit of patellar replacement versus non-replacement. I want to talk just briefly about periprosthetic patellar fracture. It is actually less common than distal femur periprosthetic fracture and more common than tibia. The incidence is about 0.05 to 21%. 99% in surfaced patella against 1% non-surfaced patella. So the most common complication now is fracture. It's more common in revision than primary. Most common to be seen post-operative than intraoperative fracture. Most of the fracture occur around 1 to 2 years of the surgery. 45% asymptomatic, 88% without trauma. Risk factor that increase the incidence of periprosthetic patellar fracture about host factor include male obesity and high level of activity. About operative factors, revision surgery, as we said, large central big design, metal-backed patella. And this is the large central bigs and metal-backed patella. Surgical technique that increase the incidence of patellar fracture, devascularization of patella, even with excessive fat, bad oxygen, lateral patellar release, and cauterization lead to thermal necrosis. Over resection of the patella, leaving less than 12 millimeter of the patella will increase the risk of periprosthetic patellar fracture. Patellofemoral component, of course, is one of the main cause. Prosthetic malalignment and oversized femoral component. This is a classification of patellar fracture, periprosthetic patellar fracture. Type 1, it's proximal or distal pool. Type B is less common, transverse or vertical fracture, and classified to B1, whereas the component is stable and intact extensor mechanism. B2 component is loose. B3 component is loose and there is bone loss. And type F is patellar fracture without resurfacing. Treatment option, non-operative, over-reduction internal fixation, two-stage revision, re-implantation if there is adequate bone stock, more than 10 millimeter of the patella, patellar resection arthroplasty with severe bone loss. Complication of patellar fracture, high rates of non-union, and ORIF, it's up to 88%. The lack of extensor mechanism, which represent is most reported cases and lead to more anterior knee pain. Indication for surgery in periprosthetic patellar fracture, disruption of extensor mechanism, loose patellar component, and patellar maltraction. And this is an example of type of periprosthetic fracture and treatment. Exceptional consideration in open patellar fracture. There's two ways to treat. The first strategy is two-stage, which we use in our department in Royal Medical Services. First of all, removing of all implant. Then after ensuring that there is no infection, because open fracture by definition is infection. Then re-implanting. The second strategy, limited approach, consisting of only debridement and then followed by osteogenesis of the patella. Take home message. Up to now, there is no significant study showed that patellar resurfacing is beneficial more than patellar resurfacing in total knee. We recommend that patellar replacement is unnecessary unless absolute indication that we are mentioned. Management of patellar periprosthetic fracture should be according to the classification and indication. Open patellar periprosthetic fracture need more attention and care. Thank you.
Good evening, dear colleagues. Thank you for staying for this late time now. My talk will be incidence rate of surgical site infection post-limb salvage surgery in musculoskeletal tumor patient at Royal Rehabilitation Center. An ounce of prevention is better than a pound of cure. هذا حكي ابن سينا من أيام 1980 ميلادي. Some history of endoprosthetic reconstruction. In 1940, Austin Moore and Harold were the first to use endoprosthetic reconstruction using a proximal femur replacement for a giant cell tumor. In 1970, Francis and Markov developed a prosthesis to replace the distal femur and the whole femur. As the demand for endoprosthetic reconstruction grew, a wide variety of implants became available and a lot of companies. In 1988, the first successful universal modular system was introduced as modular segmental replacement system for home medical, which is now available as the global modular replacement system that we use it as a Stryker or home medical. There's a lot of types of endoprosthetic reconstruction. It's first for the hip and distal femur, total femur, proximal tibia, proximal humerus, scapula, elbow, total humerus, intercalary endoprosthesis, and expandable implants for skeletal immature patients. And now there's a 3D printed for the pelvis. There's some, this is some examples. This is an endoprosthesis reconstruction for distal femur and proximal tibia. This is distal humerus with elbow. This is a proximal humerus endoprosthetic reconstruction. And this is proximal humerus with reverse shoulder. This is a proximal tibia endoprosthesis. And this is distal femur and proximal tibia endoprosthetic reconstruction. And this is proximal femur with a bipolar or tripolar we use cup. The idea of our resection is the pre-planning that the modular system give us the advantage how you can resect and you can reconstruct it by the modular system. You can see in the picture how is the large the tumor that we resect. This is the proximal tibia reconstruction endoprosthesis with patellar tendon reconstruction. This is a proximal humerus endoprosthesis reconstruction. And this is a proximal tibia. We use the lateral head of gastrocnemius flap. This is a proximal tibia endoprosthesis. And you can see in these pictures how is the wounds are, how big the wounds that we use and local flaps. This is this picture give us the trial. We use it before the definitive implantation of endoprosthesis to know how this make easier for us how to choose the length, proper length for reconstruction. So the indication for endoprosthesis is malignant bony tumors and invasive benign bony tumor that behave aggressively like giant cell tumors. And sometimes we use it in revision reconstruction as total knee and total hip. Endoprosthetic replacement advantage, there's early stability, early mobilization for the patient, and early weight bearing, and shorter operating time and hospital stay, incomparable with a biological reconstruction. early introduction of postoperative adjuvant chemotherapy, and good functional results in most of the cases. The definition of surgical site infection defined as the infection within 30 days if no implant is left in place, or within 12 months of surgery if an implant is left in place after the operation that occurs in the part of body where the surgery took place. Even the orthopedic surgeries are categorized as a clean surgery according to Centers for Disease Control and Prevention. There's some cases with infection, and this will increase patient risk for morbidity and mortality. There's a lot of risk factors for surgical site infections. Preoperative and intraoperative and postoperative are summarized in this table. We can see here in our patients, especially the oncological patient, have a lot of risk factors preoperative, like chronic anemia, and there's blood loss using ephedrines. There's a lot of risk factors for these patients. In our study, we retrospectively analyzed 28 cases of musculoskeletal tumor patients who underwent limb salvage procedure by megaprosthesis in the musculoskeletal tumor department in Royal Rehabilitation Center between January 2016 to December 2019. In this study, we detected the occurrence of surgical site infection post-operation less than 30 days and more than 30 days as the definition. The data collected from the operative note, documentation, patient files, and culture reports, laboratory tests, and the infection control committee at Royal Rehabilitation Center. We had 3 cases who had surgical site infection out of 28 cases. The surgical site infection incidence was 10.7%. The surgical site infection less than 30 days was 2 cases, and the male to female ratio was 2:1. The most frequent location of surgical site infection was the knee post-proximal tibia resection. The most common infective organism was methicillin resistant Staph aureus. Now allow me to show you this case. This is a 21-year-old female patient presented to our clinic, was managed outside as a right distal femur pain and swelling, found to have an osteolysis in the distal femur. The surgeon did some job for diagnosis, and hopefully, unfortunately, he had the diagnosis right as a right distal femur osteosarcoma. But he did not meet the guidelines for biopsy taking for oncological patient. You can see that, thank God, he take the incision with on the medial side for the definitive surgery, but it's the length of the wound was big, and the drain malpositioned in the anterior compartment for this patient. So our plan was be aggressive, and we discussed the amputation with the patient, and she refused. So we go for an aggressive surgery for her and resection all contaminated area with tumor cells. So we had to do a resection, like a triangular resection with the biopsy tract, and we managed to have a local flaps with help of our plastic colleagues, skin graft. Unfortunately, most of our patients presented to our service at an advanced stage and managed by non-musculoskeletal oncology surgeons. And this is a challenge for our patients. So in conclusion, in this study, we found the incidence rate of surgical site infection post-limb salvage surgeries with reconstruction by megaprosthesis in musculoskeletal tumor department at Royal Rehabilitation Center is comparable with the reported incidence in the literature, with the most common infective organism, which is methicillin resistant Staph aureus. Thank you very much for your listening.
بروفيسور، مساء الخير للجميع. Today we will talk about giant cell tumor of bone and treatment strategies in biomedical services. About our objectives, it will be about introduction, presentation, and treatment modalities, what's new in treatment modalities. About giant cell tumor of bone, it's one of the commonest benign and aggressive tumor that you will encounter as an orthopedic surgeon. They are derived usually from mesenchymal cell. First was introduced in 1818, and then Virchow first described the recurrence and possible degeneration into malignant. It's the sixth most common benign tumor with female slightly higher predominance, and the third decade is the peak age. It's somehow rare to be seen in children, but still it can be seen. And the metaphysial epiphyseal location is the preference of the long bone. Usually it arises in the metaphysis with the distal femur and proximal tibia accounts for the majority of cases, about 60%. And 75% of giant cell are localized near the articular end. And as we said, 60% around the knee. Usually can be subchondral and may invade the articular cartilage. And it's common to be seen associated with ABC secondary type. How do they present? Usually they present with pain. 85% might present with a tender palpable mass in the region of the affected bone, and some present with atrophy or weakness, and some present with the pathological fractures. About the radiological presentation, they're usually purely lytic with more coarse trabeculations, and they can mimic malignant appearance tumor. So that's why a biopsy is a mandatory in these cases. Unusually to see a preosteal reaction with a pulmonary mets compromising 5%. Don't forget, please, the risk of malignant transformation, and it's more common to be seen in lesions affecting the wrist and the hands. Here's how at first they look like on an X-ray. Some transformation, if you leave it, it will not be stable, as we said. And on the CT scan, it's purely lytic. And on MRI, it is usually an intermediate signal. So sometimes with soft tissue extension, usually it is surrounded with the periosteum. The bone scan, it has a classical sign of a donut sign, which is often hot in the central and cold in the spot. It shows hot often with a central cold spot in the center of the lesion. What about the treatment strategies? Our goal in treatment, it is usually directed toward local control without sacrificing the joint function. The keystone in treatment is the intralesional curettage. It's usually best balance between controlling the disease and preserving optimum function in the majority of cases. And the recurrence rate of intralesional curettage alone is about 50 to 60%, but with adjuvant treatment, it decreases to 10 to 20%. But bear in mind that adequate removal of tumors seems to be a more important predictive factor for the outcome of surgery than the use of adjuvant. This is how it looks like when you open a giant cell tumor. Be generous with your window. Things to be considered for the best results: making a large cortical window to access the tumor, use of a headlamp or dental mirror combined with multiple angle curettes, a high power bear to break bony ridges help to extend the curette, and the pulse-style jet lavage system used at the end of the curettage help to bear raw cancellous bone and physically wash out tumor cells. What about the adjuvant intralesional curettage? Phenol can be used, hydrogen peroxide, cementation, or cryosurgery. What about cementation? Cementation has shown that in encouraging results regarding the decrease of recurrence rate. The exothermic reaction, first, it might kill the neoplastic tissue, and the polymerization of methyl methacrylates may produce a local chemical cytotoxic effect, cannot be excluded. And methotrexate and adriamycin have been incorporated in bone cement and other drug delivery systems in attempt to decrease the recurrence. Cryosurgery, not commonly used in our practice. We should know that it's usually hazardous to the soft tissue condition, and there is a risk of a vascular injury and a fracture. Here's some of the cases. After cementation and curettage with supplementation with fixation. What about the reconstruction of the residual defect? As we said, it is a challenging process, needs to be done with a meticulous and experienced surgeon. Large defect, usually, they are most of the modalities are either cementation or a bone graft. What's the advantages of bone graft? Usually it undergoes remodeling along stress lines, and once it is incorporated, reconstruction is permanent. The drawback, it's usually limited. The donor site morbidity, allograft is expensive somehow, and a recurrence is difficult to spot. What about bone cement advantages? Usually, as we said, it's cytotoxic, thermal effect, and there is a good indication for recurrence and immediate structural support with a rapid weight-bearing ambulation. Here's another case which underwent cementation and prophylactic fixation with it. What about the drawbacks of cementation? It is not a biologic. It is weak on shear forces. So there is a risk of fracture on torsional and shear forces, and not to be used in the neck of femur area. And there is a risk of long-term degeneration in articular cartilage with subchondral lesion in weight-bearing areas. About subchondral lesions, this slide can be summarized in this one. If you have an articular surface, it's better not put your cement up to the subcortical, subarticular surface. You put your graft in this area, and then put an area of a gel foam, and at least put your bone cement. What about wide resection and subsequent reconstruction? Sometimes it's hard to salvage your joint, so the end will be endoprosthesis, or sometimes a resection without a reconstruction, like in distal ulna or proximal fibula. Other options, as we said, megaprosthesis, biological reconstruction, autograft arthrodesis, vascularized fibula, TSF and Ilizarov, and osteoarticular allograft. About the local recurrence, it is usually related to the surgical margin and characterized usually by pain. It is somehow difficult to see if you use a bone graft when you use it, but if you lysis or failed development of a sclerotic rim between the cement and cancellous bone may suggest a recurrence. And total serum acid phosphatase could be used as a tumor marker. Most of the recurrence usually happens in the first 2 years, but still long-term follow-up is needed, and complete clearance is the major contribution factor in prediction of a local recurrence. Treatment usually with curettage and cementation if it recurs, and early detection is important to preserve the bone. Here's an area, here's an example of one of the patients which unfortunately had a recurrence. First of all, cementation and fixation was done. If you see on this slide, the translucency is seen around the bone cement. So this is an indication for a recurrence. So underwent a cementation and refixation using the same modality, and till now the patient is fine. Here's another example of distal femur giant cell tumor. First of all, biopsy was done and curettage. Unfortunately, later on, the patient fell down and underwent open reduction internal fixation. If you can see, there is the plate is applied on the medial side, so predicting your future plan that this patient might need and other surgeries, and that's what happened. So if you see on the lateral X-ray, there is an area of a recurrence. So the patient underwent endoprosthesis and resection. About the embolization, it has mainly 2 roles: in unresectable areas and in areas to be used before surgery to decrease the blood loss. The biphosphonate. Biphosphonate usually it is a targeting osteoclast giant cell, inducing apoptosis and limiting tumor progression. A recent study has shown that rinsing of morcellized bone graft with biphosphonate prevent resorption, and it's likely to reduce the risk of mechanical failure. What about denosumab? It is a monoclonal antibody that binds with the rankle and inhibits osteocleistogenesis. Still now not that commonly used, and there's a lot of studies about this topic. About the chemotherapy and radiotherapy, usually there is no rule for chemotherapy in these cases, but radiotherapy usually for aggressive, not resectable cases can be used, and for recurrence cases, this is a modality that can be used. About the malignant giant cell tumor, we have either a primary malignant or a secondary. Primary malignant usually treated as a primary bone sarcomas, and they are treated surgically, and the secondary malignant, usually we have a previous giant cell tumor that transformed into malignant form, and they are usually have a poor prognosis, and they can transform into any form of osteosarcoma. About the metastasis, as we said, about 5%, usually they are identical to the primary lesion, and the majority goes to the lung, but it can go to any area of the bone, pelvis, paraortic lymph nodes, any area. Complete excision is usually successful with good term survival. Although metastasis is bad, metastatic disease in giant cell tumor doesn't carry the same poor prognosis as a malignant tumors, and therapy should be directed at achieving adequate local control and, if possible, complete the excision of the metastatic lesion. Here's one of the patient who underwent, unfortunately was found to have a giant cell tumor. Complete resection of the tumor with a safety margin was done. The patient, unfortunately, we see on the other X-ray, presented with a recurrence. Biopsy was taken and confirmed for a giant cell tumor. Later on, the patient progressed. Trial of a limb salvage was done, but unfortunately, he was ended with amputation. On the final amputation, amputee part, he was found to have a malignant transformation. Not the less, the patient had also a metastasis, which he had a surgery for resection for it, but unfortunately later on presented with a larger metastasis to the lung. This is a treatment algorithm. If we stick to it, you can treat any area of the body affected. And in our study, we described different presentation for 16 patients with giant cell tumor, includes pain, swelling, fractures between 2018 and 2020. They were treated by 4 modalities, including intralesional curettage, cementation or bone grafting, in-block resection, and resection endoprosthesis. Recurrence was seen in 2 patients, one of the distal femur and one distal tibia. Mean age was 26, and 7 cases have involved the distal femur, the rest distributed between the tibia, radius, fibula, and the humerus. 1 case had a malignant transformation with METs. Take-home messages: proper and early diagnosis is important in management. Curettage and grafting is the keystone in managing giant cell tumor of bone. Usage of adjuvant decreases the recurrence rate of giant cell tumor. Bear in mind the other modalities of treatment, and each tumor has its own signature. Thank you.
السلام عليكم ورحمة الله وبركاته. بعد إذنك سيدي. So today I'll be talking about deformity correction by guided cross, especially about the around the coronal plane in angular deformities. Now, Peter Stevens said that osteotomies are considered as a salvage procedure in children. Now, deformity correction by guided growth has many names in the literature. As you see, they are described in many names because it has been studied a lot in the literature. What are the prerequisites for guided growth? Angular deformity, physis with sufficient growth potential, and deformities in any plane and any extremity can be addressed in these guided growth correction, and most commonly effective in the coronal plane around the knee. A little bit about the history. Hoyter in 1862 reported that pressure on epiphysis affects growth. And then a few years after that, Volkmann noticed that changes in compressive forces caused asymmetrical growth of a joint. Then Femster in 1933 noticed that operative arrestment of longitudinal growth of bones and the treatment of deformities. Now, in 1945, Haas has studied this phenomenon on puppies, and he has found that there is a reversible hemiepiphyseal using wire loops around the physis of puppies. And then the famous Blount on 1949, he has reported that there is control of bone growth by epiphyseal stapling by introducing this staple. Now in 1998, Metazoa introduced the screws, and he reported percutaneous epiphysiodesis using transphysial screws, PETs. In 2007, the tension band plate has been introduced, and it has improved the guided growth control of deformity correction after that. Now we have to understand that there are some physiological variances regarding the angular deformities in whom to diagnose with different patients. Some are presented with post-traumatic partial growth arrests, some with infantile and adolescent tibia vira, and some cases of skeletal dysplasias can be treated also, and some patients present with metabolic bone disorders. Now, what are the indications? The indications are simple, and a clinically unaccepted deformity with an open physis. Any patient with this is a candidate for deformity correction. Now, these patients, why do we need to do that? Because they carry a risk of osteoarthritis as a region, which is a reason that we need to manage these angular deformities. Knee varus and valgus were associated with osteoarthritis. Varus and valgus malalignment increase the load medially and laterally on the joint. So what about the preoperative assessment? As usual, we start by history, examination, radiological imaging, and some cases you go for genetic or metabolic evaluation. You have to examine the length of the limb. You have to examine the patient on the anteriorly, posteriorly on the sagittal view. You have to laterally look for as you see here in this photo, the patient may have some sort of recurvatum. You have to dynamically and statically assess your patient to be able to diagnose the problem that your patient has. Also, the stability of the knee is very important. So what do? We take standing films from hip to knee, and then we do the analysis of the lower limb. Most importantly, the mechanical axis from the center of the hip to the center of the ankle. And then we have to ensure that the physial plate is still open. We have to understand that some cases, the joints are not congruent, and sometimes we even go for CT or MRI, like in this case. As you see at the circle, there's a physial bar, so you have to address that also to be successful in your management. We really care about the skeletal age rather than the chronological age. And that gives you a very important view about the growth potential or remaining growth potential for your patient. As you see, it can be done by the by the X-ray of the hand or the elbow, as we know. So there are some principles we have to address. We know about when we are treating a patient in deformity correction, the Heuter-Volkmann law. When we apply compression to one side and we apply the traction to the other side, and how it affects the hypercellularity or it decreases the bone growth at one side to the other. There is something called the rebound effect, which is after you do an angular deformity correction by guiding the growth, if you remove the plate or the staple or whatever is capturing the growth of the other side, there is a rebound effect, and this is established in some cases rather than the other cases. So by knowing that there is a rebound effect, we tend to go sometimes for overcorrection. In some cases, there is an early closure at the compression side, and you have to be to keep it in mind while you are managing these patients through their follow-up. So what about the timing of hemiphyseal? This is a very controversial issue, but there are some algorithms that has been introduced with some new technology, of course, also. There are these algorithms regarding to the bone you are treating, the skeletal age rather than the chronological age of the patient, and some measurements, and you plot your patient, and that gives you the expected growth and the expected age remaining for your potential of growth in these growth plates. There's also an application that can also help. You plot the data and it gives you the remaining potential for your patient. And this is one example. It gives you that if it is temporary or also permanent, it gives you suggestions. So what are the types? We all know that the types are either temporary or permanent. Temporary are addressed by staples, screws, or tension band plates. Staples, starting with them, they can correct deformities in sagittal or coronal planes. They must be extraperiosteal, not to damage the blood supply, to preserve the zone of Rivere around the physis. And a rebound effect is a well-known phenomenon in the use of staples. So overcorrection when using staples is recommended. This is an example of an 11-year-old child with bilateral genovalgum according to the mechanical axis, which was more evident even clinically. Staples were placed medially, and after a while, this is the X-ray of correction, and then removal was done for these staples. So what are the disadvantages of staples? Of course, it may break, it may bend, there may be some sort of migration, and there is a potential for physial arrest. Regarding the metazoa screws, it crosses the physis. Varus correction was found to be faster than valgus correction. One example, a 10-year-old female child presented with hallux valgus. A screw was inserted, as you see, to capture the lateral aspect of the base. And 19 months after that, we have got correction of the hallux valgus clinically and radiologically, and then the screw was removed. Another case, 7-year-old female patient presented with this deformity, as you see in the distal tibia. A screw and a staple was inserted. And then 15 months later, the mechanical axis was restored. And you see also how the ankle joint now is parallel to the ground. Now, after the introduction of tension band plates in 2007, it was a big improvement in the deformity correction of the coronal plane deformities. It simply acts on the same principle, yet it allows better, faster, and more stable fixation. It is easily applied. and excellently widespread use of that plate is now present. It has 30% higher rate of correction with no permanent physical damage, which is very important. It is also called a hinge plate, but it has some sort of implant failure as it was described by Sherlock et al., that there's a high rate of implant failure, especially in blount disease. And this is why you need to know and diagnose what is the cause of that angular deformity. So because of that implant failure, there was a recent implant design modification that will allow more correction, more stable implant, and it will allow also better correction with less tension on the plate itself by allowing this hinge in the middle. So this is an 8-year-old female patient presented with right-sided genovulgum. A hinge plate was placed, and then it was corrected. And then 14 months later, we found out that the left side now has genovulgum, and the right side has been corrected. So what we did is we removed one screw on the metaphyseal screw on the right side, and now we call it the dormant plate because the plate is sleeping. We are expecting some sort of rebound effect here at this place, and we have placed a plate on the other side to allow correction, angular correction for genovulgum. And then we have corrected the left side, but there has been some rebound effect on the left side. So we went again and we placed the screw on the left side to allow the correction. So you have to keep on following your patients and understanding the principles to be successful in managing these patients. Now, what about permanent hemophyseal? It has to be done near skeletal maturity. It is an attractive option because it eliminates implant-related complications and there is no rebound effect. It can be either done open or percutaneously. Femster introduced the open hemophyseal by applying a bar or a bone graft at the growth plate so that it will stop the growth, it will heal there, and it will stop the growth. Other methods are, which are as described by Bone and Johnson, either by drilling or curettage of the growth plate. There are smaller incisions, so they were associated with shorter stay at hospital. They reduced the need for formal physiotherapy. And several series demonstrate excellent results in these types. Nothing is free of complications. There are general complications related to infection, swelling, and stiffness, hemorrhagosis, and neofusion, hardware-related, especially extrusion. One of the important complications is selecting your patient. This 8-year-old patient presented with this severe deformity. 4 plates were placed, but overcorrection happened because this patient was living away in the desert, and they thought that since the patient has improved, they just don't need to come and follow. And at 11 years, this patient presented to us with this deformity. So keep on an eye on who are those patients that you select for this type of surgery or deformity correction. Now, this paper was published in 1945 and in 1949, sorry. Just read below these lines. It said, we do not know how long, and then there is a suggestion of around 2 years, and then at the end, it says further studies is needed. Now, around 72, 73 years later, we still say the same. We still don't know how long, and we still think that 2 years is suggestive of that period needed for that, but further study is still needed also for this. So take-home messages: angular deformities with skeletally immature patients are great candidates for guided growth. Permanent hemophyseal can be performed in patients within 2 years of skeletal maturity. Guided growth control is used most commonly and most predictably and most successfully for coronal plane deformities around the knee. Thank you very much.
يعني هنا نبلش. Okay, thank you for giving me this opportunity to speak about our novel three-step algorithm for surgical treatment of DDH using a medial approach. It has been almost 100 years ago when Ludlow described his medial approach for OP reduction for DDH at 1921. Then several pioneers have developed several modifications for this approach, starting from Dr. Mao and Dr. Weinstein, then also Dr. Ferguson and Dr. Ponsiti. And to be fair, that medial approach is not widely accepted, so it is commonly to be seen in North America, but it is not as common in Europe. And thanks for Dr. Firas Ibrahim, who introduced this approach to our institution and who has done several hundred of cases over the last decade. And also, he developed the concept of a three-step algorithm for medial approach. And to elaborate more about this approach, we need to know the main indication for medial approach for OP reduction for DDH. And as you see from the X-ray, there is a dislocated right hip. And the main indication for medial approach is a dislocated hip in a child less than 12 months of age who fails conservative treatment. So our approach in Queen Rani Hospital for children is quite simple. If the child age is less than 12 months, we go for OP reduction through medial approach through the three-step algorithm. And if the child is more than 12 months of age, we operate him by standard anterior approach plus minus sorter osteotomy. عشان اللي بره يعني Okay, sorry for the interruption. So the three-step algorithm is simple, it's quite simple. The step one is by making the open tenotomies, which is adductor longus tenotomy as well as iliopsoas tenotomy. And we assess the hip reduction. And if you found that the hip reduction is stable, and we conclude our surgery and apply the hip spica. But if we found that the hip is still unstable, we proceed for the second step, which is capsulotomy. By making the capsulotomy, we remove all the intracapsular obstacles of reduction, as well as the transverse acetabular ligament. Again, we assess for the stability of the hip. If it is satisfactory and stable, then we conclude our surgery and apply hip spica. But if it is still unstable, we proceed for the last step of the algorithm, which is ligamentum teres tenodesis. And in brief, this step include detachment of the acetabular end of the ligamentum teres and make shortening of it, then reattachment to the inferior-medial acetabular rim. So the three-step algorithm is a sequential step procedure consists of three major steps: open tenotomies, capsulotomy, ligamentum teres tenodesis. Our aim is to achieve a stable and satisfactory hip reduction. Despite the different variation for the medial approach, for example, there is Weinstein variation, which goes anterior too much anterior between the neurovascular bundle and the pectineus, or the more posterior one, which include the Bergson, which is between the adductor brevis and the gracilis. However, we found that the Lateral approach is the most direct and the safe one. It is directly goes to the hip, and it is the standard approach in the Queen Rani Hospital for children. And a quick review about the surgical technique, starting from the positioning of the child, as well as making the transverse skin incision centered over the adductor lingual tendon. It is almost 3 to 4 centimeters in transverse. And we think that transverse wound is better cosmetically than the longitudinal one, which is described elsewhere. The step one of the algorithm, by making the open tenotomies from the adductor longus, then we orient ourselves to the lesser trochanter and we palpate the iliopsoas tendon, isolate it, and cut it by electrocautery. This is the first step of the algorithm. Then we proceed for the capsulotomy and remove all the intraoperative intracapsular obstacles of reduction, like vulvinar and the transverse acetabular ligament. And the third one is the ligamentum teres tenodesis, which is detachment of the ligamentum teres from the acetabular end, make shortening, and the reattachment of the ligamentum teres to the inferior medial part of the acetabular rim. We have to verify the reduction intraoperative by intraoperative X-ray and then postoperative CT scan, and then apply hip spica, and also we follow up by hip spica for 3 months and 3 months by abduction splints, and these X-rays at 6 months follow-up, regular follow-ups, 8 months, 10 months, and 12 months. So in summary, the medial approach is safe and useful method to treat children with DDH before 12 months of age. And the three-step algorithm is innovative and simple guide developed by our senior consultant, Dr. Firas Ibrahim. And we have done several hundred of cases of open reduction via medial approach in Queen Rania Hospital. Thank you.
Assalamu alaikum wa rahmatullah. My talk will be about the efficacy of lateral column lengthening in adolescent adiabatic flexible flat foot and our experience in Royal Medical Services, and which we have done a study and published recently in Royal Jordanian or Royal Medical Service Journal as an original article. So what is the pediatric flexible flat feet? About 100% of 2 years old age is flat feet. So it is one of the most common problem that parents seek medical help to our pediatric orthopedic clinics. The parents ask about the flat feet in young age, like 2 to 3 years. About 4% of 10 years in older children. So there is no something called the flat feet in age below 6 years, because the arch develops spontaneously during the first decade of life in most children. Treatment, we are going to treat always the symptomatic patients with the short Achilles tendon and tenderness under the sinus tarsi or callus under the head of the talus. So if there is a flat feet, this means no need for treatment all the time. Our guidelines for flat feet surgery or treatment is the tight Achilles tendon, severe valgus or eversion deformity of the hind foot, and failure of then operative treatment to relieve the pain. The lateral column lengthening procedure was introduced by Evans in 1975 and modulated by Mosca in 1995 by just increase the slope of the osteotomy site. Our indication in treatment of pediatric flat foot in our clinic is symptomatic flexible flat foot and flat foot in cerebral palsy patient and in patient with posterior tibial tendon insufficiency. So what is the concept of the acetabular pedis? The acetabular pedis is the area in this purple cycle which include the articular surface of the navicular, the spring ligament, and the articular facet anteriorly, and the middle facet and the calcaneum. This is the concept of the acetabular pedis, which is resemble the concept of the acetabulum in the pelvis. As you see here is the acetabulum, which is consists the ball and socket joint between the head of the femur, the same as the socket with the navicular bone. What's different here is the ball within the socket, or the ball rotate within the socket in the femur hip joint. However, the socket rotates around the ball in the talonavicular joint. Again, the acetabular pedis, if you see, this is an example for a child with hip dysplasia, and we use what is called the lateral center edge angle, which indicate how much the acetabular cover the femoral head. If you see, this is the very small acetabular lateral center edge angle, and here is the same concept that the navicular is not covering the talar head properly. We do acetabular osteotomy, mainly Salter osteotomy, to increase the coverage of the acetabulum, or the femoral head, and we see how much the angle of the coverage increase. Again, we do the lateral lengthening procedures. At this point, if you can see the pointer, this is the lateral column lengthening of the calcaneus with end of increase in the center edge angle and increasing the coverage of the talar head. So in the acetabulum pedis, the calcaneum lengthening osteotomy is same principle or same as the Salter type redirectional osteotomy in the acetabulum. So the flat feet has an acetabulum pedis dysplasia with lower center edge angle of Weiberg. It is the same principle of the acetabular dysplasia. Our prerequisites to do lateral column lengthening is to have a supple spleen valgus. The foot must be supple, corrected. The corrected by the patient can go for tiptoeing, and the tendo Achilles must be also lax. Mobile subtalar joint, or if it's not lax, we can do it in the surgery to be lax. Mobile subtalar joint and the talonavicular joint, the forefoot abduction, and we prefer to do the flat foot surgery after the age of 8 years, between 8 and 13, the preferable, because of what we said at the beginning of the lecture, that the arc is developing during the first decade of life. So the typical presentation of our patient, as you see here, how it is the medial arc is collapsed with the hind foot in valgus.
And this is our approach. This is the marking of our surgery. We see here's the fibula, and this is the sinus tarsi, the anterior process of the calcaneus, and the cuboid, and this is the calcaneo-cuboid joint, and this is the peroneal, and this is the skin incision. First step is we do the triple elongation of tendon Achilles if the tendon Achilles was tight, as it's one of the most important steps in our surgery. After doing the ETA, we are going to the skin incision and the identification of the peroneal tendon in the lateral side, because we want to elongate the lateral side. So we have also to elongate the tendon by doing Zealing tenonoplasty for the tendon of the previous peroneus or peroneus previous tendon. Then we are going to marking the osteotomy site, which about 1 to 1.5 centimeters from the calcaneo-cuboid joint. Before going for osteotomy, we have to fix the calcaneo-cuboid joint in a reduction position. Then we do the calcaneostomy. Why? Because after doing the osteotomy and starting to distract the osteotomy site, if we don't fix the calcaneo-cuboid joint, we have the problem of dorsal migration of the distal part of the osteotomy, which may end of this. You can see these black arrows, that the dorsal angulation or dorsal displacement of the anterior process of the calcaneus, and it's considered one of the most causes of failure of the procedures. Then we start to completing the osteotomy from lateral to medial. We put 2 K-wires at both sides of the osteotomy, so we can distract it using the laminar spreader, and the laminar spreader or the K-wires can protect the bone from crushing by the laminar spreader during distraction. Then we used to use the bone graft, which is harvested from the iliac crest. It's about the same side of the osteotomy, about 15 millimeter, trapezoidal in shape. And we fix these grafts in situ by using the K-wire, which is the same one that we use for the calcaneo-cuboid joint that do the reduction. This is the X-ray showing how we integrate the bone graft with the calcaneum and fix it with the K-wire. And you can see this is an AP view X-ray, and you can see how nicely the navicular coverage of the talar head. Going to the medial side as the last step of the surgery, as we have elongation of the peroneus, so we have to do plication of the talonavicular capsule and the tibialis posterior tendon to tension it. And this is the post-op. You can see the difference between the right and left side. After correction, we correct the valgus and the arch. This is the non-operative side, and this is the operative side. In some cases, if we have unstable talonavicular joint after elongation of the lateral column of the lengthening, we may end with the talonavicular joint fusion to add more stability to our surgery. Our study was done in the Queen Rania Children's Hospital between March 2016 and August 2019 with 19 feet. The prerequisite was flexible flat feet, idiopathic caused, and tight Achilles tendon. We exclude other causes of flat feet like the neuromuscular one. There was 10 males, 6 females, the age between 9 and 15 years. The follow-up duration was average 16 months. Our results criteria based on multiple system. One is the clinical evaluation scoring system, which about 10 points from the family satisfaction, improvement in standing and gait. The pain was the most important one, the subtalar motion, as well as the X-ray parameters. And we schedule it according to points. And this is the result. We can see how the preoperative score of our patient was low and how much it's increased after the surgery. And this is again the American Orthopedic Foot and Ankle Society hindfoot scoring system also was followed up. There are multiple criteria for this system, and you can see how much the preoperative and 12-month postoperative marks increased of all our patients. So I said during our technique, we use a K-wire and use a bone graft. And Recently, we modulate our technique by decreasing the use of bony graft and decreasing the morbidity of harvesting an ileal graft in pediatrics, and also using of external devices like the K-wire, and we keep them for like 6 to 8 weeks, and the problems associated with the K-wires like pin tract infections. And we used to introduce the foot system plating without the use of bony graft at all. Just we do an osteotomy, distraction, and fix it with a foot system plate. And you can see this is one of our recently operated patient, how the fracture or the osteotomy is healed after fixation with just a plate without the use of bone graft. So our study, there was no infection rate at all. Just 2 cases of wound dislocating, and local care was done for the patient, and full activity was regained after 6 months post-operatively. So the conclusion of our talk is lateral column ligament is still the most effective procedure in treating symptomatic flat foot. Occasionally, medial column bony procedures is required, especially in severe cases, and as I said, in cases of the atelonavicular joint instability. We have always check the other deformity and at the levels of the other deformity. Still, conservative treatment is the main way for treating this deformity. So the surgery is the last choice after failure of non-operative treatment. Thank you.
Our experience treating patients with patients
السلام عليكم. احنا مش عارفين نحكي good afternoon or good evening. يعني ان شاء الله تكون ختامها مسك، الموضوع كبير زي هيك. Today I will talk about hip dislocation in non-walker CP patient, and the question is, do we need to treat such a patient? We know the hip joint has a large number of large muscle crossing it, so it is particularly sensitive to muscle imbalance. We know in the CP patient we have 2 types of imbalance, either increase in the tone of the muscle or weakness. So a patient with cerebral palsy should be considered abnormal until proven otherwise. We know the migration index, which is measure the migration of the femoral head related to the acetabular. We consider 30% of migration index subluxated hip, and 60% is dislocated. Hip pathology in cerebral palsy has such subtypes. Firstly, it is normal at birth, as we see in this X-ray. Then we have a primary pathology, secondary pathology, or tertiary pathology. Primary pathology due to hypertonia and muscle imbalance, especially for the flexor and the adductor group of muscle. So the hip started to subluxate it. The secondary pathology due to coxa valga and excessive antiversion, abnormal acetabular growth lead to hip instability and dislocation. Tertiary pathology due to increasing wearing of the cartilage and also arthritis and shallow of the acetabulum lead to proximal femur triangular head. We know GM-FCS, it is a gross motor function classification system. It is a main indicator for hip dislocation. Why? Because at the level 1, which is the patient nearly normal child, has a risk for dislocation hip about nearly to 0, while in the level 5 has 64 to 90% risk for hip dislocation. So it is considered as a main indicator for hip dislocation. Why I need to treat? Because progressive hip subluxation is often painful, sitting imbalance and discomfort for the child, pressure ulcer, femoral fracture, inefficient gait, especially in ambulatory CP patient, due to limited range of motion, interfere with the dressing and perineal care. We know the painful hip dislocation considered about 50%, and it's considered a major factor that affects health quality in these patients. And when the hip begins to subluxate, it is rarely improved without treatment. Our protocol in Royal Medical Service, we started prevention for the primary pathology, reconstruction for the secondary pathology, salvage for tertiary pathology. We, for prevention, we consider the hip at rest, which is clinically by flexion contracture more than 20 degrees. As we see in this photo, we do Thomas test, either in prone or supine position. And we know Thomas test when the patient lying supine, the pelvis will have some lordosis in the lumbar, so the pelvis tilted anteriorly. So when we do a flexion of both hip, there is a decrease in the lumbar lordosis, and we keep one hip in flexion while the other start to extension. If there is start to anterior tilt of the pelvis, it is we can at that point calculate the flexion contracture, and abduction less than 30 degrees to 45 degrees. We start for soft tissue release, combine psoas and adductor longus, and adductor brevis less than 50%, and medial hamstring. We start for the patient who has hip at risk, and we postpone pony procedure in child less than 5 years and who has migration index 30 to 50%. And we avoid extensive release for the adductor group and flexion to prevent abduction contracture. And keep the patient in prone stick for 3 weeks, then start physiotherapy. For reconstruction procedure, we can do either isolated varus derotation osteotomy with femoral shortening, especially in the patient less than 7 years, and if there is no acetabulum dysplasia, combined with soft tissue release, or do combined varus derotation osteotomy with femoral shortening and acetabulum osteotomy if there is concomitant with acetabulum dysplasia. And we open the capsule if migration index more than 60%. At this pelvic X-ray, we have a subluxated hip, so no need for open capsule, just do varus derotational osteotomy with shortening to keep the head contained in the acetabulum. If in this X-ray we have dislocated hip with migration index more than 60%, we open capsule through anterior approach and removal the obstacles inside the capsule, and do varus derotation osteotomy with femoral shortening and acetabulum osteotomy according to the deficient area of the acetabulum, either Dega or Pemberton. And we added spica for 4 weeks, combined with soft tissue procedure for the other hip. If we have bilateral hip dislocation, we prefer to do stage procedure. If the hip is severely degenerated, after opening the capsule, we assess the cartilage of the head. If it is severely degenerated, we go for salvage procedure. Either we do Kassel arthroplasty with valgus osteotomy, or in older children sent to the arthroplasty team. As you see in this photo, we have severely degenerated head. So we do, in this X-ray, we do bilateral valgus osteotomy. We know a nice book, Cerebral Palsy by Freeman Miller. Our experience in Royal Medical Service, we do a study in Queen Rania Hospital between February 2017 and August 2019. 70 patients, 52 of them has GM-FCS4, 18 of them has GM-FCS5, 26 of them was male and 44 was female. Average was 8 years, between 4 to 13 years. 54 patients need reconstruction procedure, while 26 required opening the capsule. 16 patients did valgus osteotomy. Cost of the surgery with metal cost about 4,750 GD. Average theater time for their surgery was 140 minutes. The result was 92% reported improved perineal hygiene, 87% reported dramatic pain improvement, while 80% reported improved sitting balance, no wound infection, 1 mortality due to aspiration, 3 patients admitted to pediatric ICU post-op due to unstable. 92% required intra-op blood transfusion. 5 cases has distal femur fracture during physiotherapy. 1 needed surgery. 1 case had proximal femur fracture post-removal metal and fixation done. 2 cases had pneumonia post-op. Recovery period, the average about 4 months. The aim of our study to invitation to start our national hip surveillance program for children with cerebral palsy in our country. As conclusion, hip dislocation is the most serious skeletal that affects CP patient life quality, and screening and early soft tissue procedure can prevent disaster complication like dislocation. Salvage procedure can be associated with high risk. National hip surveillance program for CP patient is mandatory to prevent this problem, and this is our hope. Thanks.
Now we have some time for a few questions for all the speakers of the last session. Any question?
على هاي خلص فكرت هذا بس بالذات
لما بديت السيشن هلا
So this is a very good question, that when you put a transfeasial screw through the growth plate, isn't it considered as a permanent rather than a temporary because it may form a bar? This is a question of research. A lot of research has been done on the metazoa screws or the transfeasial screws, and it has been found that for unknown reasons, it doesn't cause a permanent growth arrest at that area, probably due to the surrounding of the growth of the area around it. But in actually, from the literature, nobody knows, but it doesn't happen. According to the size of the bone, 3.5, 4.5, according to the size of the. Mhm.
بس هاي معلومة قديمة يعني ما تسألنيش بها جبتها بس بعد لحد ال4 ملم يقول لك كان يوجد
Yes, what was mentioned in literature that especially about metazoa screws, nobody knows why, but it doesn't cause growth arrest.
Thank you.
Welcome, sir.
Which system that provides some roll and glide, and the system that we showed us, each of that provides the roll and glide mechanism of the native knee.
The most system that resembles the native knee is first of all the medial pivot system. Now, definitely. Yes, because it's a ball and socket on the medial side, very similar to the native joint, and it is, or it provides the AP translation. Now, this is substituted by the different polyethylene shape. It's a deep socket on the medial side, which provides the stability, and it compensates the ACL and the PCL. Now, there are many tips and tricks in the surgery done for this kind of knees. I've worked for maybe 10 months with Baxteen, who's one of the authorities in knee surgery in North America. He usually has a different concept, doing the valgus distal femur cut angle in 3 degrees rather than 6, to more anatomically or like biomechanically resembling the varus alignment of the knee joint, which is like 3 degrees compensated by the tibia. The tibia should be cut 90 degrees until now, and in this joint, you should cut it in 3 degrees, in 0 degrees on the tibia and 3 degrees on the femur to give you a trapezoidal balance rather than a rectangular balance. The rectangular balance works for the PS and CR. That's the old thinking of the whole biomechanical aspect of this issue. The new thinking is the trapezoidal balance. It's tight on the medial side. مشان نحشر خلينا نحكي سوري بالعربي مشان نحشر البول and socket احصل yes بالضبط مشان stability on the medial side. We preserve exactly. We preserve the MCL, the deep one, the deep branch. I mean the deep ligaments. So we never cut the deep MCL, which is usually written in every textbook, maybe in orthoplasty. Usually you have the lateral side more loose a little bit, and it gives you more native motion closer to the native one. Another point in the PS system, the post and cam prevents tibial subluxation, right? The problem in PS knees is that the patients usually complain of vague pain. It's usually related to the instability, the subtle instability present there due to the lack of this deep dish on the medial side. So they have this instability when they go downstairs, for example, specifically when they go downstairs, they don't feel it really, but it's there, and it causes pain because it hits the quads. So by hitting the quads repeatedly while getting downstairs, it causes pain. CR بحكي شغله الاخيره بس عفوا الكروشيات الثاني حكينا عن الماشين ليرنينج حكينا عن الماشين ليرنينج سيدي بس انت ما كنتش كلمه اخيره سيدي اسمح لي الكروشيات ريتيننج طبعا لها يعني خلينا نحكي الاودينس تاعه الناس they prefer it, but the problem in CR knees is that the cruciate, the PCL, the posterior PCL is really not healthy in arthritic or severely arthritic knees. So it will not do the native job of the artificial knee, at least not like the medial pivot. Yeah. Machine learning مش كويس.
لا أنا في سؤال لا محمد علوان عن جاينت سيل ولا نعطيه ولا أعطاها احنا أنا الجاينت سيل تيومر في تندون شيت فبنعطيهم أو البي في ان اس نعطيهم لو دوز راديو ثيرابي. فسؤالي if you are concerned على recurrence ولا على الساركوما do you give prophylactic radio ولا لا؟ أو لأن benign aggressive اللي فهمته. لا البي في ان اس والجاينت سيل اتس ا فورم اوف بي في ان اس. يس. اها يعني you don't give prophylactic post surgery او دكتورات. لا تعال اشكر الشباب يعني الجميع ما قصر. خلي كلمة واحدة منك.
شكرا للجميع.
الله يعطيكم العافية شباب.
يعطيكم العافية جميعا. Thank you everybody for attending our scientific day. And because of modification of the night wandering hours, we have to stop now. The last session will not be done today, and maybe done in future occasions, inshallah. شكرا لمشاركتكم.